is another into our practice. This is a 74-year-old patient with type 2 diabetes, end-stage renal failure on hemodialysis. And this patient was actually very dear to me, and I felt slightly responsible for him actually losing his other leg a few years before. He'd had an infected heel ulcer which wasn't healing, and we'd really struggled with the older Shockwave BTK technology, the S4 balloon. I'd really struggled to be able to track it into his pedal vessels despite lots and lots of predilation. So when he presented to us again with new tissue loss on his remaining leg, on his right heel and hallux, I thought this could be an option this could be an opportunity for the Javelin to really, really show its worth, given that we'd tried something in the past that hadn't really worked. He's a really good patient, compliant with all the treatment, and a very supportive family. So really someone, despite the heavy calcification and all the comorbidities, this is really someone worth fighting for. They're going to do their bit. So again, we can see this classic picture again with femoropopliteal and tibial arteries open, and then pretty much at the ankle everything starts to die out. We had to activate the Javelin catheter actually to get it down into the foot because it was meeting some resistance there, and sometimes you need to do that. It may not pass all the way to your intended treatment zone just with forward pressure alone, and you might need to drop a few pulses to help it get through. And then we were able to take it through into the dorsalis pedis, but I couldn't actually advance it any further than this. And then this is where quite a nice sort of procedural thing that you can do with the Javelin, because it's an over-the-wire device, is just take out the wire and shoot an angio to light your way around the pedal arch. And that we could see the path for the wire to go. We were able to get the wire around the pedal arch, and with some more purchase with that wire around the arch, then the Javelin was then able to track through the dorsalis pedis and around the arch. And these video loops are at twice live speed, just to show you that where we go, staying at those areas where there's a lot of resistance, and just keep applying forward traction until the Javelin scoots through, and then we work our way all the way around the arch. But when you don't feel resistance, don't waste the pulses. As Canon said, there's only 120. You want to use them where they're most needed. So at that point, when you're not feeling any resistance, don't pulse. And then when you feel resistance again, start delivering the pulses. So we did a plain balloon angioplasty around the arch, and as guided by IVUS, some distal ATA angioplasty. You see the vessel there is a lot bigger. And we end up with this result here, which I felt was mostly spasm in the dorsalis pedis actually. So we dropped some nitrate into the DP locally, and then carried on to treat the posterior tibial artery. Very easy to get the wire around now that we've already been around one way, and deliver the remaining Javelin pulses all the way down across that particularly difficult to treat area. As the posterior tibial artery crosses the ankle, you often find there's dense calcium there, and it's an area where without lesion preparation you end up with a lot of recoil. So we were able to treat that area, balloon it up, and then the nitrate has worked in the dorsalis pedis, and everything is nice and open, and we've got really nice flow all the way around the arch, with some competitive flow in the lateral plantar artery, showing that both of these tibials are now feeding into that good outflow, and he went on to heal.